else for joining. I do have to apologize because I told Sarah the siren just started going off in Shawnee. I'm at home and my dog is snoring and the other dog is freaking out and whining because of the siren. So if you hear some extra noise, that's what's going on. Once again, I want to thank you for inviting me to do this presentation. I've actually occasionally been consulted in the hospital in stroke patients and trying to start therapy on patients in the acute stroke setting. And this is actually a very active area of research in sleep medicine because we're wondering if we can make an impact in this scenario that we've, by and large, I can't say ignored, we just have kind of been up in the air, does acutely trying to intervene and improve outcomes and that kind of stuff. And as our population is aging and stroke and heart rhythm and hypertension and all that's becoming a much more greater focus over the last decade or so. So I do think it's a very timely topic. Um, as Sarah said, I'm a director of the sleep laboratory here at KU Medical Center and have now done sleep medicine for more than 20 years. This is only 10 slides, pretty low key, and this is mainly meant for your time rather than my time. So do not hesitate to interrupt, to have a question. Well, actually, I think they may want to keep questions until the end, but hopefully this is a level everyone understands, and it's going to be fairly basic, but I do want to leave time at the end for questions for you guys. So before you can talk about sleep, though, you got to talk about normal sleep, and this is, once again, something I've done for over 20 years now. So this is what we call a hypnogram. And by hypnogram, it's simply a representation of what a typical a night of sleep occurs. And what this label means is W is wake, R is for REM, stage N1, stage N2, stage N3 is kind of our newer. Everyone probably thinks of slow wave sleep was the old term, or delta sleep. Well, basically what that terminology has been replaced with is stage N3. So when you think of slow wave sleep or deep sleep, or that was kind of the old terms, it has now been replaced with N3, and N meaning non-REM. So N1 is non-REM stage 1, N2 is non-REM stage 2, and N3 is non-REM stage 3. REM is REM sleep, as you all typically think of, W. And what happens is there's this normal cycling. We typically say 4 to 5 different cycles through REM with a typical onset of stage 1, stage 2. You go into slow wave or the stage 3 sleep. You come out, may wake up for a brief time, go back into REM, stage N2, stage N3. So there's this normal cycling that occurs in healthy sleep. And one of the first things you do notice, not just in a setting of stroke, either pre-stroke, post-stroke, all kinds of health issues, is this becomes completely jumbled. There's no normal regulation. You may lose a lot, or if not all of your REM sleep, you may lose your N3 sleep. This W here is a lot more of the W. You may have 6, 8 episodes of quote W or awake. These may be 30 minutes, an hour instead of 30 minutes, but this is the representation of what's normal. This is a picture of a sleep study. I don't know how many in the crowd has had a study. This is where we hook up all that stuff to your scalp. That's what all these leads right here are. This is your right eye, left eye. That's what that stands for. These, the C4, C3, A1, A2, O, all that stands for is the tracing on your scalp. C being central, O being occipital or the back. Sometimes we'll do temporal, sometimes we'll do P or parietal, but this is all basically what we're doing is a slimmed down miniaturized version of having a full EEG looking for seizures. We have to have enough that we can quote stage sleep, we can stage arousals, we can say REM, non-REM, but we don't need the full 32 looking for seizures. Although sometimes we'll do that in the sleep lab, what we call an extended montage. Basically, we have to have enough to stage sleep, but not enough that we're looking for all those details. The eye leads is what we are using to stage REM, or rapid eye movement. That's what that stands for, REM. And that's why we have to have the eyes, because we're looking for these eye movements. You can see this is flat eyes and this is these sharp eyes, and that's why this has a label of R, because this is REM sleep. We do leg leads. That's what this right and left are. The snoring channel. Are you snoring? How loud are you snoring? This is the airflow cannula in your nose. This is your oxygen level. and this is your heart rate. And this is a standard, what we call a montage, okay? And this is a 30 minutes from here to here is a 30-minute epoch. And that's a term you may have heard also. And that is a standard quote page of sleep. So if you realize that's 30 seconds, it's going to take 2 pages to be 1 minute. It'll take 120 pages to be an hour. So as you can imagine, 120 pages for an hour. And if you're doing an 8-hour, maybe 1,000 pages. So this is the reason it takes time to review a sleep study, score a sleep study, come up with conclusions from a sleep study. So if you had a study and had a large bill that came with that study, that's why there is this large bill associated, because there's 1,000 pages plus minus of a typical overnight sleep recording. So let's get into, that's kind of the background, sleep physiology. We're going to talk a little more about breathing and sleep later, but that's kind of what we're doing when we do a sleep study. Now, this is more focused on a topic we're discussing today, stroke and sleep. As I already kind of mentioned, this is a pretty big hot topic, because can we change, improve outcomes as we're seeing more aging of the population, more strokes are more common. What should we be focusing on? What interventions should we be doing? Well, first of all, this whole low rates of screening really came up last year to the level of Medicare started saying, should everyone, when they become a Medicare enrollee at 65, have a study? Just like you get your cholesterol checked, your blood pressure checked, look for diabetes, mammograms, colonoscopy, and it did not persist or last through the screening committees, but it actually was thrown in there and discussed. Should you have a sleep study as a screening? The reason why is it's not to that degree of prevalence that everyone probably should, but it's at least now listed as one of the things, some questions to ask and be aware of. It's becoming easier to do now. We do a lot more home testing. Home testing actually came about around 15 years ago, became fairly prominent around 10 years ago. And in the last 5 years, it's become fairly standard of care. And in fact, if we're looking for just apnea, we actually can do a home test and not even do a full in-lab. The issue is it's pretty well limited to sleep apnea. Looking for other disorders, looking for dreaming, acting, looking for limb movements, looking for narcolepsy, looking for those type things, we cannot do just a home test. And even for patients that we're looking that may have only mild apnea, because it's not precise enough to distinguish mild versus moderate and severe. But if it's a standard looking for apnea, moderate to high risk in that population, and no other contraindications, a home test typically will suffice. Okay. Now, when I say home test, I don't have a picture. What that involves is a handful of things. You've got to have some way to measure airflow. If you're doing it through a cannula, you have to measure pulse oximetry. So you've got a clip on your finger. Although there is even a new device now that measures effort of breathing through a watch pad, what we call, and that's a wrist device. And they can actually measure respiratory effort just through a wrist device. So this point I kind of mentioned already, access to testing, unclear timing. We're going to get in a lot more detail about timing in relation to stroke. Do they do the test before? Do you do the test acutely when the first 24, 48 hours? Do you do the test a month later when they come back? Sleep disorder breathing, we're going to discuss in more detail. Other sleep disorders, sleep-wake cycle, insomnia, restless legs, central apnea, we're all going to talk about. Really what it comes down to are kind of these 3 points here. So do you do it, to avoid the stroke? So screen someone because 5-10 years later, if we figure it out, try to treat it. Recurrent stroke, the patient's already had a stroke, so let's do the study acutely, or do you do it later at another month, 2 months down the road? The term I'm going to talk a little bit about, this whole idea of the ischemic penumbra. And by that, what we mean, the penumbra is simply the area around the stroke. So it's not necessarily maybe the part that is already died related to the lack of blood flow, but you have this at-risk area that is possibly still viable. And that's where this idea of, hey, rather than, put the patient on aspirin a day and, get them into physical rehab and try to get them back on their feet, all those things that we know helps, can there be something else we can do acutely in that at-risk area? And this quote, at-risk area is what this ischemic penumbra terminology has been around for the last few decades. We're going to talk a little bit about this whole sleepiness and neuroplasticity too. So, sleep disorder breathing. Well, by and large, we're talking about obstructive sleep apnea, but just realize in the background of all this is another thing called central apnea. Central apnea is the idea that your brain does not tell you you need to breathe. So it's, quote, central, comes from the central nervous system. Okay. Now, occasionally patients in the acute stroke setting will have this related directly to the ischemic event. Sometimes they'll have this because they're arousing and waking up so often, and some patients develop central apneas simply because they're waking up and their sleep is so fragmented. Central apnea can be seen related to heart failure. Central apnea can be seen related to medication. So realize this term central apnea is far less common, but may still be relevant and playing a role in this process. By and large, we're talking about the obstructive apnea. We're going to talk in more detail. So like I said, both can be seen. Definitely is a higher rate, meaning if I did a study a month before, if I could go back in time and I knew Mr. Smith was going to have a stroke, and I did a study a month ago, 2 weeks ago, the day before, there would be very little of this central apnea. And Pal, he or she comes in with a stroke, and I do a study that first night, I'm going to have a lot more central apnea. We do know this. The obstructive apnea is a lot more up in the air. You know, if we did a study a month ago, 2 weeks ago, someone showed up with a stroke, is there a higher rate? It certainly seems to be a higher rate of obstructive apnea prior to. Then during the acute stroke, some patients will have an acute worsening of the obstructive apnea. We don't know exactly the physiology of why. Sedation, bad blood flow, cerebral hyperperfusion. Is there a cardiac role? Is there other? And we don't exactly know that physiology, but the variation of obstructive apnea in this setting is, somewhat unknown even to this day. In the end, it seems that obstructive apnea is more relevant to this whole process. Now, what are we meaning? Obstructive apnea, you've got the airflow going through the nose, some will go through the mouth. This patient's, at baseline was mainly nasal breathing, but there are definitely some patients that have oral breathing too. And the whole idea is there's obstruction, and that's why we call it OSA, or obstructive sleep apnea. This patient, the tongue fell back against the posterior airway. This patient, this is the soft palate. If you open your mouth and look in a mirror, you'll see the uvula hangs down here. This is where the uvula is. Sometimes it's a uvula, sometimes it's a soft palate, sometimes it's a combination of the uvula and a soft palate, both. But somewhere, someplace, this is obstructed. Now, sometimes it's not 100% obstructive, and sometimes, and some of you may have heard the term hypopnea. Hypopnea, HYP, means shallow or less than full or some variation thereof. And the idea is it may not be complete obstruction, but it's obstructive enough the airflow is decreased. So we have this all the way from obstructive to 100%. So that's an obstructive event, to obstructed enough, there's a shallow breath, that's a hypopnea. And this is where we get this apnea hypopnea index. So it's the O's, obstructions, the H's, the hypopneas. You add them together, and that's the total events. And one of the first things we ask patients, or if we're going over a study, is how bad was the apnea? And we grade the severity of how many obstructive events, how many hypopneic events. We add those two together and we, quote, index them. And by indexing, we're correcting for how many hours they slept. Someone slept for 30 minutes and they had 100 events is completely different than someone had 100 events and they slept 8 hours, right? So that's why we index them, and that's the AHI, all the events divided by how long someone slept, and that's how we get this number. And there is a fairly close correlation between the symptoms, how many times an hour, the AHI, and how sleepy someone is, their weight, their other risk factors, all those kind of things. And that's when you may have heard that number. Okay. This also is a good representation why some of our therapies work, or why our therapies work. You put a CPAP mask on, you blow air through here, guess what? It opens this collapse. It opens the obstruction, either at the tongue level, the soft palate level, the epiglottis level. You put a oral appliance, what that's doing is it's pulling all this area forward. And by pulling this area of the mandible, the jaw forward, the back of the throat opens. So that's how oral appliance works. If you do anything to shrink the tongue, we don't do it as often as we used to, that opens this area. If you do something to get rid of this soft palate or the uvula, that was the old UPPP surgery we did a lot of in the 80s and 90s. Don't do it as often, but occasionally we still do. You get rid of that area of obstruction, then it opens the airway. Now we do even this procedure we call genioglossus advancement. That's where you pull this part of the tongue forward. You literally pull it through the bone, shorten all these muscle fibers, connective tissue, and by pulling all this area forward, it opens the back of the throat here. And that's what a genioglossus advancement. And then the final fairly recent procedure we've done in the last 3 to 4 years is what we call Inspire or hypoglossal nerve stimulator. We say, hey, if we can pull this tongue forward, once again, let's not do it through a surgery, let's do it through electrical stimulation. So we wrap a lead around the nerve, and by stimulating that nerve, the tongue protrudes forward instead of falling backwards. And that's what we are doing now at KU, and it's called Inspire or hypoglossal nerve stimulation therapy. So those are all the things that we do to try to reopen this airway. Okay. With, once again, the most common being the CPAP. And like I said, I tell patients CPAP is not oxygen, it's not medication, it's an air compressor attached to a mask, attached to a hose. And you're simply using air pressure to reopen and maintain patency of the airway. All right. I already kind of mentioned this a little bit. This is unfortunately kind of the chicken and the egg when it comes to sleep apnea and stroke. And what I mean by that, if we do studies in the acute setting, sure enough, we find a higher rate of stroke compared to non-stroke patients. But was it there before the stroke? Was it there before the stroke and it got worsened by the stroke? Was it not there at all before the stroke? And then they had a stroke, he or she, and then we find the apnea acutely during the stroke. And then we bring them patients back a month later. Is the apnea still there? Or once they recovered from the acute stroke, the apnea got better. So to some degree, this is unfortunately kind of a moving target, okay? Like I said, the best evidence shows there's probably a higher rate of apnea before patients have a stroke. During the acute stroke, that apnea probably worsens in many patients. And during the recovery, some seem like it gets better, but other patients, the apnea persists. So there's kind of these three time frames when you're talking about obstructive apnea and stroke. What was the breathing like before they ever had a stroke? What happened to their breathing in the acute stroke setting? And what happens to their breathing after that stroke occurred? Now, the reason that's relevant, we're going to talk a little bit more. I'm not going to say a whole lot more about other sleep disorders. There's definitely disruption of the sleep-wake cycle, but here's the problem with that. I have a patient that came in for a heart attack. Guess what? They have it too. I have a patient that came in for even a pneumonia, a bad respiratory infection. One of the worst sleep disruptions we've seen now with COVID infection. Guess what? They don't sleep well. They have increased wake after sleep onset. Remember that hypnogram I showed you? They have a lot more of the W's, that cycle, that normal cycle, N1, N2, N3, back to REM, back to N1, N2. You just see complete disruption of that. But is it the stroke causing that, or was that occurring before? We don't know. Insomnia itself, at least 50% of patients, I actually didn't give you a number about obstructive apnea, but if you take the next 100 stroke patients admitted at KU, about 50% will have sleep apnea prior to, roughly 50%. Insomnia, someone comes in and they have a stroke, and we do daily questionnaires, about 40 to 50%. It's a little bit lower, but not much. 40 to 50% will have a complaint of insomnia in the peri-stroke period, we call it. Either hard time falling asleep, hard time maintaining sleep, or unrefreshing sleep. So insomnia is very common in this setting too. Once again, is it the chicken and the egg? They weren't a good sleeper. There's some research out there saying if we poll 1,000 patients, no active health issues, or at least overall fairly healthy, and there's a higher rate of insomnia in patients that do develop stroke later. But it's kind of hard to control for that. Were they already having some of those symptoms, or was it they're diabetic, they're hypertensive, there's other health issues? So It's not the insomnia itself is related to the stroke. It was all those other health issues were causing insomnia. And then that patient simply had a stroke. Restless leg syndrome is a little less, 10 to 20%. This may be a neurological kind of sequela of a stroke. Restless legs, we think, is iron kind of low level within the spinal cord, but it's more complicated than that even. But there's definitely a higher rate of restless legs in acute stroke setting. It seems like it does get better months down the road, but that can occur often also. Once in a while, you will have patients that have hypersomnia related to stroke. That's typically these patients have this massive stroke. A huge portion of the brain was compromised, and that's almost always resolves longer term. So sleep disturbance in stroke patients, and like kind of what signs do we look at? What's prognosis for good versus prognosis for not as good recovery? Patients had no prior existing sleep disorders, or if they did have them, we treated them. It seems that they do better. So if they already had apnea beforehand, do they do worse recovery-wise? Yes, it seems like that is true. Now, there's a handful of studies. Dr. Bassetti in Switzerland's done most of these studies. Someone comes in acutely, we don't even care. Did they have apnea before? Did they not? It's acutely right now within this first 24, 48 hours. Do they have apnea? Let's treat it with CPAP. Maybe some will get BiPAP. And do they do better? We really have mixed results. There's at least a study or two, but one of the studies that showed showed the improved outcome was 12 patients. If you only do a study of 12 patients, does that mean across the entire world, this should become the new standard of care? You can't really make that kind of conclusion. The problem is trying to apply CPAP in someone with acute stroke. If they have dysphagia, if they're having dysarthria, if they're having communication problems, and we try to put a mask on, you can imagine how difficult that can be. But there is at least this school of thought out there acutely intervening on obstructive apnea in the acute stroke setting may improve outcome. It's more of a theory than an absolute proven outcome, though, at this point, unfortunately. Bad recovery, the sleep disruption, I already kind of mentioned that hypnogram. You've got a lot more of the W's versus less of the W's. You're waking up more. You're having a difficult time. There's some say, okay, should we be sedating these patients if you're having the insomnia? Because we do know that a lot of this is based on animal models. You take a group of rats and you start sleep depriving them in the acute, induce a stroke, you sleep deprive the one group post-stroke, and you let the other group sleep ad lib. Guess what? This group of rats that you sleep deprive, every study that's looked at this, they recover less. They do worse. Now, is that the same for humans? We don't know. The interesting thing that they did find is some patients, though, if you sleep deprived before, then you gave them the stroke, that the animal model studies showed the ones that were sleep deprived prior to the stroke actually did a little better. The theory is you sleep deprive someone before, then pow, you have the stroke. If they're already sleep deprived, guess what? They sleep more because they're catching up on their sleep. So if you catch up on your sleep post-stroke because you're sleep deprived, they actually did a little bit better. So is sleep good for stroke recovery? It probably is. It's just, how do we increase that? Well, let's optimize the chance for sleep, but does artificially inducing sleep with medications improve any of these outcomes? We don't know. And there's a good, pretty reasonable thought it probably doesn't, because if we try to induce sleep with benzodiazepines, Valium, those type medicines, well, there's side effects of that medicine. If we do it with Ambien, with Lunesta, with Sonata, with all these medications, is that really going to improve outcome? If it's, medication-induced sleep, it probably is not the same as endogenous or, the patient's own body sleeping. But there is at least that idea out there. If you are able to optimize sleep in a post-stroke setting, do patients do better? That's probably true. It's just, how do you do that is the question. Few and transient post-stroke changes. This is just kind of simply, they do these detailed EEG studies, and sometimes they can even tell in EEG studies within the first 24, 48 hours post-stroke who may do better. This intact homeostatic regulation of slow wave activity, that's what this SW means, is a slow wave activity. This is that N3 sleep. If you maintain your N3 sleep, do you do better? You probably do. But once again, how do we do that artificially? There's no good way to do that. This is really what it comes down to. There has not been shown to be any medication, any specific intervention to promote healthy sleep other than treating the obstructive apnea if it's there. And we just don't know. You know, even though this slide had this drugs improving sleep continuity, that would have to be a question mark there, because we've not proven, like I said, giving sleeping aids or other medication. There's some other studies that looked at gabapentin in acute stroke, some of the medications that we use in the ICU to sedate patients. It's just not been proven that improves outcomes. This environmental enrichment, optimal timing of rehabilitation, cognitive, this is all that stroke rehab that we do afterwards in acute stroke setting. This brain stimulation is kind of interesting. We do this transcranial stimulation. We don't know that definitely improves outcomes at this point. It's more experimental, but there's a little bit of research that's looking at that. There are some animal models that said this may help, but unfortunately it's just not been proven in human beings yet. This whole risk reduction, this is a big area now also in obstructive apnea. Okay, fine. We don't know in acute setting. A patient comes in, has an acute stroke. We try to treat apnea if it's acutely diagnosed. What's probably more important than that is we do become aware that they have apnea, and at that 1 mark, 3 month mark, 6 month mark, afterwards, we try to do our best to optimize treatment of obstructive apnea, and do we avoid recurrence down the road. That's our goal, and that's probably what we should be focusing more, even in the acute setting. Like I said, this acute treatment of apnea, obstructive apnea, is still a huge debate within the sleep and the neurology field. If it was easier to do, we'd be doing it more. But like I've already mentioned, these patients are already having fragmented sleep. There may be impaired neurocognitive, so you put the mask on, they can't tolerate the mask. So there's lots of limitations to trying to do that in the acute setting, but it remains to be determined how beneficial that may be. And that's my 30 minutes, my part of the time. So